So our first presenter is Dr. Amini. I have bios here for a lot of people. I don't think I have one for you. Did you submit a bio?
That's okay.
You did? Let me ask you. Tell me about yourself.
All right, I'm a radiologist at MD Anderson Cancer Center.
That's right.
I did my PhD in computational neuroscience, and I'm talking about psychosurgery and human personhood.
We look forward to your presentation.
Thank you.
Thank you, Dr. Amini.
Thank you. All right. It would have been very unorthodox to start right on time, so 2 minutes out of schedule is fine.
We call that cultural.
Yeah, cultural promptness, yeah. So I want to thank everyone for being here and the OCAMPR organizing committee for the opportunity to share my talks on psychosurgery and human personhood. The first thing I want to do is give you a disclaimer. When I submitted the abstract, the idea was a little half-baked in my head. And ever since doing the research for it, I've realized it's actually now a quarter baked, so it's even worse than when I started. So I apologize for that. And then the second disclaimer is that this is a very complicated topic that I'm trying to cover in 30 minutes, so I'm going to be painting with broad brush strokes, and I'm going to skip some nuance, so forgive me for that. And then I'm not a theologian, so whenever you see this church icon, I want some reflection and help from you guys, if you can give it to me afterwards or during the Q&A. How can this be salvific? I'll be presenting a lot of facts in a materialistic sense and connecting it to I'm only 2 years old in Orthodox terms, so that's my limitation. So what is psychosurgery? Let's start with the definition. This is a classic definition: irreversible direct interference with normal brain tissue with the aim of alleviating mental illness. But I think we do a lot of surgical interventions on people where the ultimate aim is actually psychological cure. And I think the definition could be expanded to any normal tissue with the aim of alleviating mental illness. So why should we care? I think the way we interact with people gives us an implicit idea to the world of how we think about them, right? So if you're interacting with people as a person as a piece of meat, you're dealing with them in a certain way, and that becomes explicit in how you're dealing with them. And I think how medicine interacts with people, especially through the lens of something like psychosurgery, which is so invasive and gets at such of who we are, our core, our psyche, is a good way of understanding these models. And conversely, how the person interacts with the medical technology within this framework. We had an AI talk earlier, and how this technology interacts with us within the framework of autonomy, how we diagnose things, the goal of surgery, and the target that we're selecting for surgery. And then I want to look at how the model and this framework has changed from the early days of psychosurgery to where we are today with transgender surgery. And then looking ahead at where we're going in the future. And then as these things pile up, these little bricks in the wall, they'll show up here in this area. Okay, so this is kind of a broad overview. People who had lunch with me know that I had my cookies ready to go in case the world ends. I will have had my dessert first. So I want everyone to have this broad overview of where we're going. So I'm going to start talking about functional surgery, basically what we call lobotomies, gastric surgery, bariatric surgery, cosmetic surgery, and transgender surgery, and how each of these things shifts from what the core model is, what our model of autonomy is, how our diagnosis is made, what the aim is, and we kind of start with health, kind of blend into beauty, and then go to authenticity. And these are in quotes because these are worldly definitions of these things, and then what the target is. So before we start, let's talk about autonomy. There's two ways of looking at autonomy. There's different ways, but this is, I think, a helpful one. Engelhardt was an Orthodox Christian bioethicist who was actually part of our parish before I joined. Moral autonomy, you may have heard about Kantian autonomy. This is the capacity to basically impose a moral law on yourself. And if you have a higher value, a universalizable moral law. And that's easy to do when you have a monoculture, basically, and absolute universal values. And that's basically gone away with the concept of pluralism and relativism. So now we're left with this stump of autonomy, which is volitional autonomy. And this is, I do what I want, right? Capacity to act in accordance with your own preferences, your values are relative. And these have buzzwords: individualism. This is a big part of post-Enlightenment culture. And then now with this kind of meaningless term of empowerment that basically gets thrown out whenever anyone wants to do anything. And then technology is obviously important, surgical technologies. And like any technology, surgery can suggest, create, or impose new ends that you didn't have before that technology. And then the question comes, is the technology or procedure justified just because it exists? Or in other words, just because you can do something, does it mean you should? And the temptation for us physicians, and also specifically surgeons, is that because we have this power and this monopoly to manipulate the body, then you're just looking for things to cure, right? You have all this skill and you want to put it to use for something. And then the other part that's going to be a recurring theme is how these technologies are adapted rapidly without adequate assessment of long-term effects. And then by the time we realize it, we're like, oh crap, and then we come back a little bit, but in the meantime, we've damaged a lot of people. So let's start with functional neurosurgery for psychiatric disease, or what people kind of roughly refer to as lobotomies. So the foundations were laid in the 1700s, where people sought to free the science of man from metaphysics and spirituality. So in the 1800s, late 1800s, Broca, Wernicke, these people discovered that there's parts of the brain where if the patient has a lesion, they'll have specific functional deficits. And that made us think, oh wow, we can map the brain. And if you get a stroke here, you lose your power of speech, then that's where speech happens. If you're losing your power to understand speech, that's where cognition of speech happens. So this gave, this is a great discoveries that made people think we could understand the brain. And kind of moved the noose, basically, the center of our soul, from the core to the brain. And then the first lobotomy started happening very quickly after that. So 1860s, 1870s, these discoveries by Broca and Wernicke, and then the first lobotomies in 1888. And then these moved on, and finally in the 1980s, the last lobotomies for mental illness were performed in France. And my wife is Belgian, so I'll avoid the French jokes here. So for 100 years, we were experimenting on patients with this thing that we now look back on and say, oh my God, that was barbaric. For 100 years, we did this. But the bricks that have piled on is the idea that the brain is the seat of the soul. We did think we knew where the source was, so we were actually treating the source. And then this concept of recklessness. So let's talk about some of the early pioneers of this of psychosurgery. Gottlieb Burckhardt was a Swiss, I believe he was a psychiatrist, and this is his toolkit, or a replica of his toolkit. And I don't think he was necessarily, doing reckless things. He had a small set of patients. These were incurable, so the equipoise was reached, I think, back in those days. But very quickly abandoned by him. The effects, the results were not great. Next up is Moniz from Portugal. He was a neurologist, again, not a surgeon, and basically 50-50. And again, these things were refractory. So, but leave it to the Americans to really go take this to the limit. So this was Jackson Freeman, Walter Jackson Freeman. He was kind of a showman. He'd lightly sedate the patients, developed this ice pick method, and you just go through the eye and then wiggle the needle and destroy the frontal lobe. Sorry, not the cortex, the frontal lobe. And results, as you can imagine, were not great. 15% died for the procedure. And finally, after 30 years, he was banned from doing the procedure. And Rosemary Kennedy was one of his victims, for the people who remember that. So this was the procedure, but we've gotten a lot more sophisticated now. We can map actually specific areas with deep brain stimulation, and this is the only FDA-approved for psychiatric condition is obsessive compulsive disorder. There is research on the other ones, but not great. This concept of the kind of machine brain lives on, though. We've just gotten so much better at mapping neurons, their connections, and their strengths of connection. And this idea of the connectome is taken off. So in 2010, this scientist basically said he is his connectome. This is basically all of who I am is in the brain. And this is the model that persists to this day, despite multiple failures to actually do anything with it. And this is the idea. It's kind of a Gnostic idea of the, you know, a disembodied brain that you can just plug into anything. And of course, the press loves this stuff and just kind of, they just eat it up. So and we'll come back to this later. So the summary, brains are circuits, there's no spirituality involved. And at least the standard for diagnosis was objective, and our target was this kind of a moral autonomy of normal mental health. Let's move to bariatric surgery. So it's complex, right? Big ag, the foods we eat, trauma, mental illness, hormonal, genetic, gut biome. We can talk about a lot of different things, but these are what contribute to obesity. But we've decided, you know, dealing with all this stuff, it's kind of hard. Let's just, you know, wire your jaw shut. Kind of gross, so let's just bury it, right? Cut the stomach. We've basically given up, right? We think obesity is such an emergency for your health that let's just get it fixed. You deal with the stuff later. And that's the person. We don't care. You're just a tube. Let's tie it up. And these are the different surgeries. These are not benign surgeries. When I was an intern, I lost a few patients, not because of my fault, I hope, but one of them got a PE after Roux-en-Y bypass. And these are not easy surgeries. And the patients that come in do have these spiritual wounds, right? They're listed here. You can, the references are below. But significantly, the American Society of Metabolic and Bariatric Surgery says psychopathology, including eating disorders, are not contraindications for bariatric surgery. You would think you want to isolate the source of the problem, but they just kind of, let's just deal with the downstream. No formal standards exist for preoperative assessment. And when they do any preoperative assessment, it's basically for improving post-op outcomes. Anxiety seems to be refractory to bariatric surgery, and actually some of the issues that you had going in get transferred to other issues like self-harm, alcohol, substance abuse, and things like that. And of course, whenever something like this happens, people feel instinctively that there's something wrong. And maybe the way we respond to them are not the best. So the reactionary response has been like, oh no, there's nothing wrong with being obese. And now we have this to deal with. So this is the summary. The autonomy is still a moral autonomy. We have this more normal BMI that we're shooting for. Diagnosis is still objective. There are very strict objective criteria. People want you to, the surgeons actually do want you to be in a state where you can benefit from the surgery. But we're not dealing with the core issues, the spiritual wounds of these patients. And then this is where I really fell into a rabbit hole with cosmetic surgery. But we need to step back and understand how this happened. So this concept of health has evolved. We just think of health as absence of illness. But the WHO in their founding document, in their constitution, has this very broad definition of health: complete physical, mental, and social well-being, and not absence of disease or infirmity. So that's a very broad definition. And before, we all love to blame the WHO for stuff, but our own founding documentation, Declaration of Independence, is the pursuit of well-being, basically, right? This is not a foreign concept. So we've gone from treating disease to treating dis-ease, basically treating any kind of discomfort as disease and basically medicalizing everything, right? Any feeling you have, any discomfort, there's a pill for that, there's a surgery for that, and we've come to expect this medicalization of everything. In 1979, Lash, in his book on narcissism, talked about this, even back then, about this therapeutic model of everything, where well-being, health, and psychic security take the place of salvation for us. And then this concept of beauty, right? We have this worldly concept of beauty, which we all have. But then there's, the church's opinion on what's truly beautiful. And again, this is my spiritual kind of immaturity. So if anyone has any insights into this, that'd be great. If you go back to the founding surgeons for cosmetic surgery, they were kind of skirting on the edge of the field. And the kind of the real plastic surgeons, the one who treated deformities, the ones that treated war injuries in World War II. World War I was a big change for them with all these trench injuries. They used to refer to them as decorative surgeons. And I think that's actually a better term for this, because we forget cosmetics seems very clinical. So basically, you take normal bodily structures, you do stuff to them to make it more pleasing. So where does the customer come from? How do we create these customers for cosmetic surgery? Hollywood, magazines, mental illness is a big part. Multiculturalism and globalism, right? You're in your small village, the prettiest girl in your village is who you have the crush on. Now you have, I don't know, Scarlett Johansson, sorry sir, on like every screen in town, and suddenly the prettiest girl in your village or the prettiest guy in your village is no longer enough. Advertising, a lot of it by plastic surgeons. And then egalitarianism, right? Why can't I have what someone is born with, right? America, through hard work, I can be anything, even prettier. And then this consumer model of healthcare, where as long as you pay and you want to, you can get anything you want. But the bottom line is we live in this society where self-esteem is externally driven. And the normalization of decorative surgery is preventing us from addressing this. Every person who gets prettier but with plastic surgery is adding to the body of people that are pressuring you to get plastic surgery. So a lot of spiritual issues with plastic surgery customers, cosmetic surgery customers, intimate partner violence. This is sad, but a lot of other issues, past trauma, things like that. We know about body dysmorphic disorder, higher prevalence, no surprise. Depression, suicide risk, personality disorders. And again, preoperative psychiatric assessment, you'd think with all this data, you'd be coming in, getting psychiatrically assessed. Hey, maybe your issue isn't your nose. Maybe the issue is that you have this self-image issue that's the problem, the spiritual hole. There's some people who are saying, hey, let's select out people with body dysmorphic disorder, not operate on them, but we know that doesn't happen. And this is the crazy thing. We put healthy people under anesthesia, cut them open to chase ever-shifting beauty trends and transcend these limitations of birth and ravages of time. And just to step back a little bit, in our culture we've gotten used to these things, but I think some cross-cultural comparisons are helpful. In Korea, women are self-conscious about their calves. This is apparently a difference that they recognize. We think that's weird. This is completely normal to us, right? I was born in Iran. We're the plastic surgery nose job capital of the world. This is, that's kind of weird, right? Oh, but not so much. Weird? Why not? This guy needs help, but this guy, he went to a surgeon, so that's okay. And let's talk about medical experimentation and decorative surgery. So saddle nose deformities were common in the era of syphilis. So having a saddle nose was a huge social stigma. So they started using paraffin injections. Initial results were fine, right? You fill it up, and until you realize paraffin moves and melts. So this application of paraffin to the nose, extending to the breast, and getting it out was even more challenging and disfiguring. So, hey, how about silicone? And this is a woman that in the 60s or 70s became famous for getting silicone injections directly into her breasts. Until, it doesn't melt, but it does migrate, it forms granulomas, and now we've evolved to the point of silicone implants. But for more than 100 years, we did this to people. This is the woman who wants to look like Ivanka Trump. She has had 13 plastic surgeries to get there. And it's easy to look at her and focus on her and go, oh, this poor woman, what's wrong with her, or feel superior. But there's a surgeon that did this. There's an anesthesiologist that did this. There's a nurse that was present. And 13 sets of these people did this to her. So what does that say about us? We've gone from being experts or the moral standard bearers in medicine to just basically go to this consumer model where the patient is now a customer, right? And I think if you say cosmetic surgery patient, you're kind of lying to yourself. And the goal is this ever-changing concept of beauty subject to trends. But let's zoom out. I think maybe we don't know how far we've come because of the slow boil. This is 1907, this pioneer of cosmetic surgery, he was laughed at. People thought he was unethical, 1907. This is 2024, Anytown, you guys have this Westlake dermatology, and this is completely fine. And David Foster Wallace talked about the goal of advertising to create an anxiety relievable only by purchase. And basically, cosmetic surgery advertising presents this loop. You set these examples on the billboards, you see these as a child, you're like, oh my God, I should have those abs. I should have, that, whatever. And that kind of feeds itself. And it's easy to be hyperbolic about this, But imagine an oncologist poisoning a town just to get more customers, right? I think it's a little, I agree it's a little bit unfair, but not by much. So who is the person? So the idea is to fix the body with the aim of fixing the soul. And we know the body and soul are linked, but it's not a one-way street. And then the medicalization, right? This is one of the pioneers of transgender surgery when he was talking about cosmetic surgery. Basically the only justification, because back then people were still a little bit queasy about cosmetic surgery, and they would do these things, do these studies, they feel better, self-esteem, depression, anxiety. They created this diagnosis of inferiority complex that cosmetic surgery was supposed to fix. But he was very blunt. This is it, we're doing this. But the question is, does it? The results are robust with self-esteem. Everyone has a better body image and self-esteem, at least for the part that was operated on. It may transfer to some other body part. And these are the frequent flyers in the cosmetic surgery world. Psychiatric disorders mixed at best. There's some evidence that breast augmentation, actually your suicide risk goes up, but maybe the control wasn't so good. But it's not, you're not fixing the soul. And then the second question is the fact that this decorative surgery improves emotional health say about us, and as us as customers of it, and us as the society. When I was showing those pictures of the before after, you saw some of those pictures, and you're like, yeah, this is actually, she looks better, he looks better with this. That's our fault, right? We're feeding into this. And then what can the church offer as alternatives? All right, and this is the part that's going to probably get me canceled. So transgender surgery. And again, I want to stress with all of these patients have real pain, real spiritual struggles that they're going through. They're coming to us, and by us I mean the medical psychiatric profession, for help, and I feel like we're letting them down. And this brings us to the concept of authenticity. This is just as in my Substack feed last week. This poor woman, she's in her 30s now, but she's still lamenting that when she was a teenager, she could not get red hair, purple hair, whatever, and piercings, because she couldn't express her true self. And that is how we in society see authenticity, our external reflection. But our authenticity in the church is to grow in the likeness of Christ, right? We are our true self when we reflect Christ. And again, this is, and then, so where did all this stuff come from? So in about 100 years, this stuff's kind of been boiling under the surface. We think this just came out of nowhere, but started about 100 years ago in Germany, and then for about 20, 30 years when I was doing a literature search on this stuff, the terms we're seeing now, and we're like kind of like going, oh, this is kind of, doesn't make any sense. This stuff's been in the medical literature and being used. So it's just been waiting for this social media age to kind of just take off. And then the thing that's been kind of just putting everything together has been this queer theory, which is that all these norms and traditions that we have about sex categories need to be destroyed, dissolved, and blurred to give us this new utopian society where we can all be our authentic selves. And this is a great book by Benjamin Cabe. He's an, I believe he's, I think he's Orthodox, but he has a great book on the Orthodox philosophy on this gender stuff. So all of this stuff is now added in. And this is all the stuff that goes into creating the transgender patient. And we kind of know what all of these are. The interesting thing is the autism spectrum disorder, the binary thinking they have. It's like, if I am a girl but I like soccer, I must be a boy. That seems silly, but that's kind of the logic that's being applied. And the ultimate issue is that we live in a sick world that assaults us with disordered representation of sexuality. We saw that with the cosmetic surgery stuff, right? The medicalization thing. So on the one side, the transgender advocates are saying that this is a healthy form of human variation. But then this healthy form of human variation needs medical and surgical treatment. So it's not an internally consistent system here. The APA is not helping. They've changed the definitions of gender dysphoria, gender identity disorder to gender dysphoria, put in these kind of softer terms in order to destigmatize the condition. And again, we know these patients are suffering. These are just some of their psychic wounds. And then, like cosmetic surgery, these interventions boost self-esteem, reduce depression, reduce stress levels, improve quality of life. But that by itself, this pursuit of happiness is not the right endpoint. And then more recently, there's data that long term, these are not, they either don't do anything or have negative effects. And we know social stigma contributes to this. Any healthy society has stigmas on behavior that is not within the realms of normal. So the gender ideology is change your body. If anyone questions it, they're evil. Instead of actually going and saying, why do you have this issue? Society has to change around us. And again, that's a very individualistic thing that's baked into our culture. And then like cosmetic surgery, gender ideology creates an anxiety relievable only by obeying gender ideology. So those are the assumptions. And then where are we going? The medical consensus is luckily starting to align with reality, but the ideology is here to stay and is baked too far into our system. I'm very negative about this. And the ultimate goal is transhumanism. This is one of the advocates of transgenderism to transhumanism. A billionaire. There's a lot of these people that are actually pushing in this direction. Not all, but this is one of the avenues. And this is a pipeline to transhumanism. And there's nothing new under the sun, right? This is just Gnosticism, the disembodied brain and body. So solutions. Let's start about non-starters. I feel like organized medicine, is not going to do this. We're not going to kick out the cosmetic surgeons, and the APA is not going to reform. There's no political solution, nor should we want one. We don't want the politicians to intervene in this. We might score a win if, let's say, we can't do, doctors can't do transgender surgeries. But that's just the start of this slippery slope where they're now telling us what to do. And then what they're probably going to do is give us a half solution. Don't do it to children, but continue to take advantage of vulnerable adults. And that's not a solution at all. Solution, again, Benjamin Cabe, in his great book, he says the Orthodox Church does not have a dichotomy between bodily sex and internal sex. You're the whole person, right? And the Orthodox Church is good at discerning truth, right? Just because you have a feeling doesn't mean it's truth. And this is where the church, together with mental health professionals in the church, can help. And again, we have the model of anorexia. You affirm the pain and suffering without feeding the distorted thoughts. And then reorientation of this identity from the self and the idolatry of the self back to Christ. Some references. And then acknowledgements for the people who've been extremely helpful in discussions with this paper.
We have time for a question. I'll just say I did find your bio, Dr. Amini,
Okay.
And I apologize for not looking in the right place for it. And it completely underrepresented your thoughtfulness and brilliance, so it wouldn't have done me any good anyway. So.
I have a question.
Yes.
About the first transgender in the 1920s was in Germany.
Yeah.
Was that at all related to the, experimentation in
So it's actually the opposite. It was a gender institute that was run by Hirschfeld, and the Nazis shut it down and burned his books. So it's a kind of an awkward part of history that kind of goes against it's just like the one thing that you can be like, maybe, but obviously the rest, that's okay.
Thank you very much.
Thank you again.
Yeah.
Next we have Dr. Abdul Malak.